I have, I guess, a couple of disclosures. The first is that it's really my honor to be here and to be a part of this panel. Other than pulling bullets out of children or walking down the hall and holding a mother or a father after their child has been shot, I personally am not an expert in the gun violence research and work that you're all doing. The second disclosure is that this panel is not here to sugarcoat what we're all here for. So there are some graphic pictures, and we are going to take this head on. I really appreciate having two experts and folks who really are at the front line of care for victims of gun violence. To my right, Sheldon Teperman is the Trauma Medical Director at Jacobi Medical Center. He's also the acting system chief for trauma for New York City Health and Hospitals, and he's a lifetime board member of New Yorkers Against Gun Violence. I also have Dr. Douglas Isaacs with us, who is a deputy medical director with the Fire Department of New York. He is the director of the Emergency Medical Services Fellowship, which is jointly run between Northwell and the Fire Department of New York. And he is an emergency medicine physician at Long Island Jewish Hospital and Northwell Health. So thank you both for joining us today.
Good morning.
Can you share with us a little bit about what in your life brought home this crisis, this problem that we're all facing today?
Jose, it's said in public speaking, you should always start off with a little levity. So this is my Christmas tree in Hoboken, and my wonderful brother Lou, who's your vice chair and head of transplantation at Northwell. By the way, Lou, congratulations on the first liver transplantation at Northwell, successful last week to you and your team. So Lou's coming to my house on Saturday, and he's going to say what he says every year. Sheldon, what's with the huge Christmas tree? You know we're Jewish. So it's not about religion. It's about it's going to get pretty rough here pretty quickly. The things that I see and that Doug sees are horrible. And I actually do believe in this concept of peace on earth and goodwill towards man. And I take call every Christmas, because I'm the Christmas Jew, and this will be my 30th Christmas, and I tell you that once a year, we as a country tend to put our guns down and hug each other. And so at the end of all of this, and Mr. Dowling's wonderful initiative here, maybe we can do that 365 days a year. But the theme that we're going to be talking about, you, me, and Doug, is do you see what we see? Do you see the horror that we see? So it's 1995. I'm a young trauma surgeon at Jacobi, and this whole disaster is laid at my doorstep with my colleagues, right? A young man, schizophrenic, walks into a shoe store and shoots 9 people, including five dead, with a mother and her 2 children. And I end up operating on the shooter and do emergency procedures in the emergency room. This is a horror show. And in terms of what made its first impact on me, Jose, as I was a young trauma surgeon, this had its horrible effect on me. And look at, so this topic is on the front lines. So not only did I have to operate and deal with the fact that we had lost this mother and her 2 kids, but the aftermath of this with the next slide. So trauma surgeon's job isn't done when the carnage is done, right? So this is me testifying. I had to testify twice in open court, and I'm a younger, much skinnier trauma surgeon. So, and I'm gonna challenge for a moment some of the things that were said earlier. This is a too complicated a problem. This is not that complicated a problem. I have so who here thinks that Michael Vernon, who was subsequently convicted, serving 5 consecutive life sentences for this horrible deed, who here thinks that he should have had a gun? Can we show a show of hands? No, nobody thinks that Michael Vernon, who was adjudicated schizophrenic, should have had a gun. 40% of gun transfers in the United States of America happen without a background check. And it's a little odd, Jose, that the dumb trauma surgeon is the first person up here in an hour and a half that's telling us this. So this is not a complicated problem. He should not have had a gun. The 9mm, Winter-Mutant wrote, is the most lethal wounding vector or agent that we have, right? Even mustard gas doesn't kill like the 9mm. So this is a political problem. I'm sorry. And I know this is an uncomfortable thing for me to say, but we go nowhere on this 40,000 deaths until we have universal background checks. I'm sorry. It's uncomfortable. If healthcare is getting into this, no, advocacy needs to be number 1 on your list, not number 4. I have a good friend, Karen Brohe, who runs the London Trauma System. He has your job and my job combined. The Royal London, the beautiful St. Mary's, a brand new trauma system and building. I visited Karen a few years ago. There was a gunshot victim. He was a VIP. Medical students from across the city came to learn and see of this one gunshot. No, this is a purely American problem, and it's a purely political solution.
Thank you. Dr. Isaacs, tell me about what brings you to this moment in this conversation.
I want that court artist to do my portrait. So from a perspective as a pre-hospital responder, as medical director, responsible for training and response, as well as wearing my emergency medicine hat, I think about the faces. I think about the faces of our victims. And not just their face of victims, but their families. When we have to tell them whether it's outside the hospital or in the emergency department, we take them to the family room. And we have to tell the family members that their loved one has died. Not forgetting those faces for the rest of your life. Hearing those voices, the crying of anguish, of having to tell that their loved one is dead. And I wanted to advocate for pre-hospital providers, but not just them, but all frontline providers, including the emergency department, physicians, the support staff, the nurses, and of course our EMTs, paramedics, and firefighters, and police officers, and so on. The psychological support, because they have to respond, take care of these victims and their families, and then they got to switch it back on to then take care of their next patient or their next response. And we don't properly address the psychological support of these providers. And I'd like this to come out of this today, that we think about them. On a more personal level as well, this is a picture of my friend Tyler. These are my best friends growing up, and we just had a holiday of Thanksgiving, and this is part of we call our turkey bowl every year. And Tyler, who we all looked up to, it was our idol growing up, killed himself with a gun, which he should never have access to. So every Thanksgiving, my friends and I look at this picture every year now.
Thank you. Dr. Teperman, tell all of us, share with us some more of what you see on the front lines as a provider in the trauma bay, and then Dr. Isaacs as an emergency medical physician, and on behalf of the FDNY EMTs who are out at the scene.
So I'm going to let you all in on a secret. So the military teaches if you want to kill someone, shoot them in the middle, center mass. Why is that? Because God or Mother Nature, depending upon your belief system, put all the good stuff in the middle, right? The aorta, the heart, spinal cord. So this is a victim in our old hospital. And our expert from the CDC talked about what the problem is, right? This is a peculiarly issue of young men of color. That's who's being killed in this country. Homicides, the 40,000 minus the suicides. That's who's dying in this country. So here's a young man of color on the operating table, and someone's done a good job of shooting him in the middle. And so we were high-fiving because we fixed him, right? Duodenal injury, cava, ureter, liver. So my colleagues and I are all high-fiving because he's fixed.
This is one bullet did this.
One bullet, center mass. So we did great, right? But no, right? What's that, right? So the doctors in the room know that that's a retropulse fragment of the L5 vertebra. And he wakes up and he's paralyzed. And so we have the 40,000 gun deaths, and we have the 135,000 injuries, but we never talk about this. I have in my mind, when I close my eyes, I see a legion of young black men that are paralyzed, that will never walk again, and maybe never move their arms again, that are not part of this equation, that no one talks about. I speak for them. Do you see what I see? And this, right? This is a real thing. This is a real case, a real patient that I operated on, right? Can you imagine? America, are you crazy? We are shooting at pregnant women. Thank God. Thank God the trauma surgeons and my colleagues and the nurses that day saved that child and saved that woman. The sound of that screaming baby in my trauma operating room still haunts me. That's a sound we should never hear. And then this. This was in our brand new trauma center. This is a young man. This is an open thoracotomy, an ER thoracotomy, an anterior lateral thoracotomy. And do you see that clamp? That clamp is on his aorta. It's not moving. And why is it not moving? Because he is dead. Do you see what I see?
Dr. Isaacs, tell us about what the FDNY sees at the front lines.
Okay, it's not just about statistics, which we're talking about today a lot. On average, we see about 1,000 gunshot victims a day. What came out of some of the mass shootings of Columbine, Virginia Tech, a working group was put together, and out of that came a three-pronged approach: stop the killing, stop the dying, and stop the destruction. And what part of that came out of, next slide, is the idea of a rescue task force, which is a coalition of pre-hospital providers that include the brave men and women of our law enforcement and our first responders of EMTs, paramedics, and firefighters. And the idea that it's not normal to run towards the sound of gunshot, right? Instinct is to run away. But these brave men and women in uniform go towards the sound of gunshots. And the idea that law enforcement is going to mitigate that threat, and then our other first responders are going to stop the bleeding, do critical patient care interventions, and hopefully get them to the hospital alive, where in the emergency department, as well as our trauma service, help save that patient. So this has been a great working kind of coalition that we put together, and it's been a tremendous, in terms of New York City, this is a national phenomenon, but New York City has been very dedicated towards this. So.
Thank you. Dr. Teperman, what can we do about this? Is there anything as frontline providers, can you share some thoughts about what you've done and what we can do to contribute?
So I would call this my tilting at windmill slide. So that's me in the United States Senate's Russell Office Building with Carolyn McCarthy and Patrick Kennedy, who obviously were their family members, terrible victims of gun violence. And this is 2003, and I am standing in front of the AR-15, exhorting Congress to reauthorize the assault weapons ban, which, by the way, was highly effective. And I think even Dr. Webster will tell you it was, despite the gun lobby's assertion to the negative, no, it was highly effective. But you know, my voice was not loud enough that day. And almost a decade to that moment, that same gun that I'm standing behind was used to mow down those 20 children and their teachers in Newtown. Now, I heard our leader today, Mr. Dowling, our wonderful leader today, say, let them come. And I think what he meant is Mr. Dowling, Northwell, the trauma community, the healthcare community has broad shoulders. And I welcome the company because I've been doing this for 20 years and I'm a failure, right? So I started off, there were 29,000 gun deaths in America when I started off my advocacy. Now there's 40,000. So clearly I'm bad at this, right? And 20 dead children. But I have a feeling the broad shoulders of Mr. Dowling and Northwell and the Healthcare Consortium would do a better job than I did. And now Sadie Mitchell. So you can see I'm kind of pissed off and kind of angry. So Sadie Mitchell in 2009 was shot. A bullet comes through her window. She's watching TV at age 92. And now she's brought to Jacobi. And her bullet enters the left hip. So and she's brought in with a homicide detective. She's talking to me. She seems like she's fine. Homicide. And I say to the homicide detective, what are you doing here? He's like, Doc, 92-year-old woman comes in, shot. This ain't going to work out. And I'm like, you'll see. You'll see. I'm going to fix her. But I take that x-ray, Jose, and she's been shot center mass. And now she's dying. And I take her upstairs to the operating room. And you know that picture that we showed of that young man ripped open? And I rip her open. And I think about my mother, and I think about my failed advocacy, and I think about what's cooking up inside of me because I am angry, but I can't fix her. There's no way I'm going to fix her. As I'm tearing through her body, no. Her heart, and I realized I got to keep it together. And her heart stops in my hand, and I'm covered in her blood, and I step back, I fall across the back wall, and I start to cry. And the anesthesiologist comes over to me and says, you know, you're the great Sheldon Teperman. Trauma surgeon's supposed to leap tall buildings in a single bound. Your residents should not see you like this on the floor in a pile of blubber. And I said, let them see Let them see, how can they not feel this? A 92-year-old woman, what is wrong with our nation? We have this combined sickness, and it's not getting any better. It's not getting any better.
So what do we do?
So, I pivoted after Sandy Hook and after Sadie Mitchell. I looked and said, well, my politics isn't working. I need broader shoulders. So let's pivot. And Dr. Webster talked about the beginnings of Cure Violence. So this is hospital-based youth violence intervention programs based on the Cure Violence model out of Chicago, which is credible messengers, violence interrupters, hospital-based. So at Jacobi, we have a grant from the Department of Criminal Justice Services. It's annual recurring grant, and we have these credible messengers and interrupters that go into the communities and actually physically take the guns out of kids and teach them a better way. And since we started this program, which Cure Violence at Jacobi is called Stand Up to Violence, there are programs being replicated like this across the city with great success. We have a 40% decrease in the number of shootings across the 3 zip codes we're associated with. This does work, and and I'll accept the science on this, and we should roll this out across America.
Dr. Isaacs, can you talk a little bit about what the FDNY has been doing in response?
Sure. Similar to the opioid crisis, this has really kind of unified us across the public health sector, obviously gun violence. The fire department has more than doubled its training. Normally, in terms of some of these critical interventions, hemorrhage control and so on, has been an EMT or paramedic skill, but we've also trained all our firefighters as well across the board on the department. Also, a lot of great programs from Stop the Bleed and other programs that these gentlemen have been instructors and others in the room. I would kind of also advocate, how can pre-hospital providers be involved in terms of, because we're a reactionary force, right? We respond to these shootings, whether it's single shooter, mass shooting, what have you. But I don't think there's a lot of discussion how we can intervene, because don't forget, we're out there in the public. And how can we best utilize them? And normally it's not their role, because again, we respond to emergencies. But maybe we're missing a big link in this whole chain of how to stop the violence. I do want to mention one thing before you finish up, Sheldon. When you hear first responders bid farewell to each other, right? Most normally say goodbye, good seeing you, see you later. You always hear them say be safe. Because every time they put that uniform on and they respond to a job, they don't always going to go home. And so, again, please keep them in your minds. And when you think about intervention programs, again, psychological support and so on, and training, please think about them.
Thank you. So, Dr. Teperman, I've heard you talk about your prescription for America as a trauma surgeon. Can you share with the group what your prescription for this problem would be?
Yes, but before I do, Doug, I want to say to you and all our first responders in New York City, thank you for your service. So it's not complicated. It's not complicated. We don't need to, it's like parachutes, you don't need to do a randomized controlled trial, right? So all we need to do nationally is close the gun show loophole with us 40% of no background checks. We need to fix the background check system. We need to ban assault weapons across, these weapons of war across the United States. They do not belong in the streets of New York. Ban high-capacity magazines, fund things like Cure Violence, and we end the carnage. And we should begin. We should begin.
So I'd like to thank both of you for taking both such personal positions in terms of sharing with a group like this what has brought you here, for sharing your professional work, for what you do day in and day out for all of us. And I'd like to highlight, I know there's many of you here, the American College of Surgeons has a December 15th deadline for a new fellowship that is actually geared towards this. I think it's another thing on the front line that we can look towards. It's called the Firearm Injury Prevention Clinical Scholar and Residence Fellowship. And Dr. Cools is here, who can probably speak more specifically about it. I don't know where, there she is back there. And she and that's really our larger organizations working at the front lines, the AAST, AFFIRM, the WTA, EAST, the COT. The community of surgeons and emergency providers really trying to tackle this on the front lines. So thank you all for your attention this morning. We very much appreciate the opportunity to share our experience.
Right on time.
Right on time.